finishing up here with the serological method of tissue typing. So let's started on this. So here you want to find out what kind of combination of HLAs a person has on their lymphocytes, and so you are using a panel of anti-HLA antibodies, whichever ones they find their target, and on the stem region of the antibody that has found a target, it opens up a binding site for complement. It will activate complement, and one of the results of complement is that it makes cellular contents leak out, or in this case we're using a blue dye that will leak into this damaged cell, and then when the cell turns blue, then you know that this particular antibody has found a matching antigen on this lymphocyte. Let's take a look some more at transplantation issues. Transplants, of course, it's a big thing. If you need an organ because of damage, because of an accident, or whatever may have happened. So the waiting lists are long. There's very few tissues to come by, and on top of that, you need to be a perfect match to somebody that is willing to donate. So the transplants, especially if the match is not perfect, they can be attacked by T cells and destroyed. So that's how a lot of transplant, these graft versus host disease, how that plays out, and then the graft is not usable. Also, macrophages can attack, and complement fixing antibodies can also attack. So there are a few sites in the human body that we call privileged sites, because you don't have to match the tissues, and so these sites you can just transplant from anybody into anybody else. This would be true for cornea transplant and for heart valve transplants. So a cornea, you don't have to worry about tissue typing or anything. You can transplant from one human to another human, and it works. Same is true with heart valves. Now, of course, the best case scenario would be that you have completely matching tissues, and that bears the question, how about stem cells? Well, stem cells are undifferentiated cells that are capable of generating many, if not all, different stem cell types, So embryonic stem cells, those are the best. They are pluripotent. They can generate all types of cells. And then adult stem cells, which we still keep around, they are pluripotent stem cells. That means they can become various types of tissues, but not all tissue types. And so the idea here is, how about if I need a new liver, can I harvest my own stem cells from the liver, adult stem cells, and then grow the liver that I need back? And well, there's some success along those lines, but we're just not there yet. There's a lot of issues surrounding that. So, but anyway, maybe in the future, stem cells will be the ticket, and then we don't have to worry about long waiting lists for a transplant anymore. So here, this a figure that shows you how you might derive embryonic stem cells. So here, of course, you have this is just a blastocyst, and then you can use these embryonic stem cells. They can become any tissue, and if you would separate out these cells from this blastocyst, and you could differentiate them into any tissue that you need, if you know how to tell the cells what type of tissue they're supposed to become. And that's kind of an issue. You may have these stem cells, these embryonic stem cells available, but then how do you tell a stem cell that it should become some nervous tissue? So that's there's still quite a bit of work to be done. Okay, let's move on to grafts, and there are some terms that you should know. An autograft is when you're using your own tissue. An example for that would be if you do a bypass surgery and you need to take a piece from an artery from a different part of your body. So let's say from the leg, you're taking a piece from a blood vessel, and then you're using that blood vessel piece to go around a clogged or blocked area in, let's say, a coronary artery. So that would be an autograft, use of your own tissue. Or sometimes people do that when there's severe burns, and then using a patch of skin from another place of the body and graft that back onto the burned area. Isograft would be if you have an identical twin and you can use their tissue, which is genetically identical. So that's pretty much almost the same as autograft, I guess. Genetically, for sure, the same. Allografts, that will be the use of tissue from another person. Xenotransplantation, that will be non-human tissue. So sometimes you can have pig heart valves have been used in the past to use for humans. So sometimes you can use another animal and transplant some tissues that you need. But there is always, you have to use a privileged site most likely to overcome hyperacute rejection, and it's a response to non-human antigens. Despite being careful, a lot of times what happens is graft versus host disease, and that can result from transplanted bone marrow or even other tissues that were transplanted. So that's severe. Graft versus host disease is something you want to avoid. A lot of times you want to give the patient has received a transplant graft. You want to give them medication to suppress their immune functions. And there are some popular medicines. Some are related to cortisol because cortisol will reduce immune functions. Also, cyclosporin is very popular. And tacrolimus, they suppress interleukin-2 and disrupt cytotoxic T cells. There are other medications. As far as I know, the most popular really for preventing rejection of a graft is cyclosporin. So that in the context of immunosuppressing a patient, cyclosporin is a lot of times the way to go. There are other medications out there. Sometimes you can also use a monoclonal antibody. So here's one example given. Basiliximab is a chimeric monoclonal antibody that blocks also interleukin-2. Now let's move on to the immune system and cancer. Cancer biology and cancer research, there's been a lot of work has been done for several decades now, and we still don't have a cure for cancer. But probably the biggest breakthrough has come with cancer immunology. And so basically you are using your own immune system to fight the cancer. And the latest thing is to reprogram your existing immune system cells, usually T cells, to attack the cancer. So, but for that, you would have to take out the T cells from the T lymphocytes from the body, and then have them undergo a gene therapy, basically, re-educate the T cells, and then re-implant them into the same patient. And now they have been educated to what their target should be, and then they go after the cancer. And that's been the biggest success in recent years. Now let's first take a look at the big picture here. So normally cancer cells are removed by the immune system. The scary thing is that we have pretty much at all times some cancer cells in our body, but good thing is these cancer cells, they have tumor-associated antigens, and that marks them as non-self, and then your immune system is recognizing that and killing them. So normally the cytotoxic T lymphocytes, the activated cytotoxic T cells and macrophages, these guys here, they lyse the cancer cells. They directly just kill them. The limitations of that system is that every now and then something will escape. Also, if your immune system is not so strong anymore, then there's a higher chance that one of those cancer cells might escape the immune surveillance. Also, sometimes they have no antigenic epitope for the immune system to target, so that would be sort of stealth fighter cancer cells. Also, tumor cells, they reproduce very quickly, and so that makes it hard to keep track of them. And the tumor oftentimes becomes vascularized. That means it makes its own capillary bed and diverts a lot of nutrients and oxygen for its own growth into the tumor area, and that adds to the problem for the immune system to recognize the cancer cells. Here's a picture that shows you what a cytotoxic T lymphocyte can do to a cancer cell. So here is your cancer cell, this big old thing right here. And here's your little cytotoxic T lymphocyte. And basically it's man-to-man combat, and the cytotoxic T lymphocytes, they're very strong. So basically they are shooting down that cancer cell, and here the cancer cell has disintegrated and the T lymphocyte was successful. Here are some immunotherapy approaches for the treatment of cancer. So the first bullet here is endotoxins from bacteria, and there are these Colles toxins. They can stimulate tumor necrosis factor, the TNF, that interferes with the blood supply of cancer. So basically you're choking the blood supply for the cancer and starving the cancer, and then that limits the growth, of course. Then there are some vaccines that are available. They're literally labeled cancer vaccines, especially this one here, cervical cancer, the Gardasil. So cervical cancer almost exclusively is due to the human papilloma viruses. And so if you're making a vaccine against these human papilloma viruses, and that's that Gardasil vaccine, then you can prevent cervical cancer. Same principle for liver cancer and hepatitis B. If you're vaccinating against hepatitis B, then you can prevent many of the liver cancers that are due to hepatitis B infection. Another approach is using monoclonal antibodies that target certain receptors that are found on particular types of cancer. So first you have to type out the cancer and figure out what type of surface receptors the cancer has. And then you can target those surface receptors with the monoclonal antibodies, these MABs, monoclonal antibodies. They are linked with toxic agents, and so as soon as the monoclonal antibody has found its target on the cancer cell, then it will drop a toxic bomb on the cancer cells and basically kill the cancer cells. And it's very specific, so much more specific than these generalized chemotherapy agents that they have a lot of side effects. Also, Herceptin for breast cancer is a good example for using monoclonal antibodies. And then any medication, there's a lot of them out there these days, that end with MAB, monoclonal antibodies that are linked with toxic agents. They are available for a variety of different receptors that are expressed on cancer cells. Now moving on to immunodeficiencies. So that would be the absence of a sufficient immune response. It could be because you were born with a lack or an insufficient immune system. So that would be a congenital immunodeficiency because you have defective or missing genes. And so now you have an immunodeficiency from birth. And acquired immunodeficiencies, those are developed during an individual's life. They are usually due to either drug use, cancers, or infections. And here is a mouse, a little nude, hairless mouse that was infected with Mycobacterium leprae in the hind foot, right here, the site of the infection right there. You might wonder what a nude mouse has to do with immunodeficiency. Well, so here's the story. So these nude mice, they have no thymus, and because they have no thymus, they have no cell-mediated immunity. So the immune response to infection by something like Mycobacterium leprae or Mycobacterium tuberculosis depends on cell-mediated immunity. So that means if you don't have cell-mediated immunity, that would be an important way to research or find out more about how the body handles, an infection with Mycobacterium leprae in this case. Here's a list of immunodeficiency diseases, and pretty much none of the ones on this list except one you will ever have heard about. So, of course, everybody knows about HIV infection that leads to the disease AIDS, acquired immunodeficiency syndrome. All the other ones you probably have never heard of and probably will never hear of them. And so because of that, we are going to be spending all our time, the remainder of this lecture, on HIV/AIDS. This virus destroys CD4+, so positive for CD4 cells, and that will be mostly helper T cells, so the CD4+ cells. And basically it induces cancers and also other infections to take hold. People mostly die from lack of an immune response to a pathogen or even to cancer. Acquired immunodeficiency syndrome, AIDS, was first discovered in the United States in 1981. It was a cluster of cases of pneumocystis, pneumonia, Kaposi sarcoma, and loss of immune function that were discovered in young homosexual men. And you have to understand, Kaposi sarcoma and pneumocystis pneumonia, they are very rare, especially in young, otherwise healthy men. And in 1983, the cause was discovered. It's a virus that causes the loss of immune function, HIV.